Hi, sir. Shubham here, sir. How are you,
Hi,
sir?
I'm good evening. I'm all right, Shubham. Thank you very
Great,
much
sir.
for inviting me.
Arey, sir, it's a pleasure. Our pleasure, sir. Our pleasure, sir.
Actually, मैं तो भूल ही गया था कि है और I didn't get the mail.
Sir, I mailed you to you at sanjaysharma5@gmail.com.
No, आया पर वो पता नहीं कहाँ उसमें चला गया स्पैम में.
बताओ.
And I was out of Bombay because I lost my brother-in-law, unfortunately.
Oh, okay.
फैमिली में ट्रेजेडी चल रही. So I just came back 2 days back. So मैंने कहा यार मेरे को कुछ तैयारी करनी पड़ेगी. मैंने कहा तैयारी डिबेट करना है तो तैयारी करनी पड़ती. फिर
आपको क्या तैयारी का जरूरत है? आपको क्या तैयारी का जरूरत है? कैसा बात कर रहे हो?
नहीं. You see, in a scientific meeting हवा में बात नहीं कर सकते. ठीक है, मेरा एक्सपीरियंस है, वो बात सही है, लेकिन हवा में बात नहीं कर सकते.
Great, sir. Great.
और मैंने सुना है अनिल is doing fantastic work in Tata. I've never had a pleasure to meet him. Now I can see. Hi, Anil.
So, sir, good evening, sir. It's a pleasure meeting you, sir.
Yeah, मैं आजकल टाटा में आता ही नहीं हूँ, टाइम ही नहीं मिल रहा है, और आप लोग बुलाते नहीं हो, इसलिए और नहीं आता.
सर अभी तो वर्चुअल का जमाना है सर अभी.
ये बात सही है. No, I keep coming now. Actually, now we are trying to start our ICC meetings with with Sudeep and all. So now we have to start. We can before COVID era we were doing a lot of meetings in the third floor. और हमने आलू बोंडा और वो सब चाय पीते तो रोज रात 7 बजे. तो अभी वो फिर से चालू करना है हमको फिर से. तो वो that scientific.
Please come.
Yeah, I will come and meet you.
Sir, 2022, na? Right?
Yes,
2022.
Yeah, 2022.
I think it's first week of November. I don't have exact date, but 2022 November. It was earlier in third week, but now I think it's first week. I think 4th, 5th, 6th something. Because we're trying to push for that Geo Garden.
Oh,
yes,
okay.
Yeah, so there we have a capacity of in a big hall 20,000.
Yes.
Okay.
So hopefully this corona goes away, then we'll have that number. Otherwise, it's going to be difficult.
Sure, it will go away because it's 2022 November. So we have.
You never know. They will produce some more new strain, so you don't know about it. Because suddenly in Mumbai, in last 1 week, there is a huge spike of cases.
Yes.
And though we have taken, I'm sure you guys have also taken single shot.
Yeah.
But we don't know. I mean, there is some confusion. Just now I was talking to somebody that shall we go ahead tomorrow? I've got 4 weeks. And they said, no, don't take it for 6 weeks or 8 weeks.
I know, sir. It's a new
no. But see, what is happening is government is pushing because it is convenient for them. कि पहले घर सब डॉक्टर्स को दे दो. So they went to the local public. But all scientific evidence, whatever, I was talking to all people, Shashank Joshi, Ansari, all those people who were involved, Rahul Pandit, all those who suffered themselves in oncology, ICU people, they are saying that it is no use taking it if your IgG is good. So I think we should do all IgG and see if it's there. And then if it is high IgG, wait for it. What's the problem? What's the hurry?
I know.
So that's what it is. At least I wanted to have it for purpose of. Hi, Geeta.
Hi, good evening, sir. Good evening. Good to
Dr.
see you.
Geeta, you got a
After
haircut.
such a long time.
You got a haircut.
I'm happy to have you on board.
Yes, thank you very much.
At a very short notice. So I'm sure we're all looking forward to this.
No problem, ma'am.
Great debate.
So that's why I said we'll have to wait at least for 6 weeks. So I'm not in rush to take anything before 6 weeks to 8 weeks. They're saying that what are we IgG? So we have decided to do IgG now tomorrow for the team, and then see if we can have IgG. Then we'll wait for 6 weeks. We'll see. If it is not there after first shot, the IgG is low, then we'll go ahead and take the shot. So that's what we have decided. But there is a lot of confusion. Still, people do not know. But they are trying to push it. I was told the government is pushing because they want to, get rid of doctors first, then the general public. That's what the issue is.
Chalo. Sir, we'll start. It's 8:32. So, sir, I make you a co-host, so now you can control your audio as well as your video, sir. Right?
Sure. Prashant.
Okay, great, sir. Okay, so let me just put the recording on.
So, I was talking to Geeta yesterday.
Yeah.
What is the timeline for me? Though she said for students, so I have taken a little bit of few teaching slides as well before, just as the general, before we start actual debate, so that they can understand a little bit.
So, sir, it's a teaching program only, and
that's what she told. I was not aware of it.
Yes. We just put it as a debate to make it more interesting. Otherwise, Anil is very nice to all of us surgeons, and there is.
No, Baba, we can't survive without them anyway.
So obviously, please take your time. There's nothing against it, sir. The more we learn, the better it is. Sir.
Yeah, the more we learn, the better it is.
Yes.
No, because see, your youngsters need to be explained. See, esophagus is not a very common disease.
Yes.
And at least first year student, at least if not the final years, they find it a little difficult to understand the level of nodes and what exactly means the surgery means, or what is the type of surgery that we do, and what the radiation does to the tissues. And all those things needs to be initially told before we go ahead for debate. But yes, we'll put our points at which is the best treatment as you ask for it. So we'll try to do justice to that too.
Sure, sir. Sure.
Yeah.
Okay.
So whenever you are ready, I'm ready. I'll show my slides.
Great, sir. Great. So
Great.
we have a little setting up of the context by Shubham Jain, who will talk about why there is a controversy. He'll just present a couple of slides, and then we'll hand it over to you, and followed it by Anil, and then we'll open it to discussion. So I'll just formally start by starting the recording. So just give me a minute. Okay, so good evening, welcome. It's a Wednesday evening, 8:30 p.m. and we are back with the Cancer Academy. In this month of February, we are focusing on CA esophagus, and last class we had a brief overview on the surgical practice of esophagectomy by Dr. Prashant Penuwadu, who described to us what are the types of surgery, the lymphadenectomies. But now we are moving to the more pertinent question, which is about the management of CA esophagus. And it is not just about surgery or radiation, but it is about choosing the best treatment option for the patient. And those who deal with esophageal cancers would agree to me that a very common point of discussion is what kind of neoadjuvant therapy is the right type for a patient for locally advanced CA esophagus. And why we are discussing locally advanced esophagus is because that is the most common type which we see in our clinical practice. So I have with me two of very eminent speakers who do practice a lot of CA esophageal management in their own clinical practices to shed light on this. But before I introduce them and I hand over it to them, I actually have a very close colleague of mine, Dr. Shubham Jain, who is also a thoracic surgical oncologist, who I requested to put into perspective why we are debating this topic. You know, if all of us agree that we need NACT or we need some form of neoadjuvant, but why is this? There's a debate about NACT RT. So Shubham, over to you. I'll just play your slide. Shubham, just give me a minute.
Thank you, Cancer Academy, for giving me this opportunity to put into perspective the biggest debate that is currently there for the management of esophageal cancers. As you've rightly put, the majority of cancers that we see in our country are the locally advanced ones. And because of that, the question of what treatment to give before the surgery is one of the most pertinent questions that all of us are struggling with. So it actually is a question of which is a better recipe for the treatment of esophageal cancers. We all know that the advantages of the neoadjuvant chemotherapy are that it can control the micrometastasis early because the blood supply to the esophagus is intact. It improves the delivery and the effectiveness of both the chemotherapy and the radiotherapy. It is able to downstage the tumor and facilitate a curative or an R0 resection. And it also gives us an opportunity to identify the biological behavior of the tumor while it is in situ. So there have been multiple trials across the ages focusing on different modalities of neoadjuvant therapy. The most prominent of these are the OEO trial, which is primarily looking into the neoadjuvant chemotherapy, the MAGIC trial, which is looking into the perioperative chemotherapy, and the CROSS trial, which is looking into the preoperative neoadjuvant chemoradiotherapy. All these trials have definitely demonstrated a benefit in the patient outcome. But is the neoadjuvant therapy always without any side effects? No, not at all. It gives an increase in morbidity and mortality to the patients. It can cause impaired healing of the anastomosis. It increases the chances of pulmonary complications in our patients. It makes the operation surgically, technically difficult, and multimodality therapy may be difficult to administer to the patient. The patient may never turn up for the surgery, which is the actual most important part of the treatment for esophageal cancer. Now, having spoken of that, do all patients need neoadjuvant chemotherapy? So what has been seen across systematic reviews is patients with clinical T2N0 or earlier than that may not need neoadjuvant therapies. So it is only the locally advanced cases, either which are node positive or more than T3 stage. These are the patients which have been found to be benefiting from neoadjuvant treatment. Any patient less than that may just go in for upfront surgery. There have been trials such as the Neoadjuvant trial, which has evaluated the chemotherapy and the chemoradiotherapy and has failed to find any significant difference in the outcomes, thereby questioning the need for adding radiotherapy to the neoadjuvant treatment. Similarly, there has been a meta-analysis called the Jockwis meta-analysis, which has barely found any difference in favor of the chemoradiotherapy. The jury is, and also for the neoadjuvant chemoradiotherapy or chemotherapy was for G-junction adenocarcinomas was answered by a systematic review where they found no difference in terms of median OS despite a higher PCR rate and a reduced local regional risk, recurrence risk for the combined approach of CT-RT. But having said all this, the jury is still not out there. There are future trials focused at looking for squamous cell carcinoma, such as this Japanese trial. And apart from that, the subsequent slide shows the trials that are directed for the adenocarcinoma, the esophagus and the neoadjuvant. So while we are waiting for the result of these trials, I would let the stage open for our two debaters to fight it out for what is the best modality. I take the honor and pleasure of welcoming Dr. Sanjay Sharma to take us and teach us further from here regarding the his point of view on the neoadjuvant therapy for esophageal cancer. Thank you.
Thank you, Shubham. Good to see you. And you rightly set a stage. Broadly, you have already mentioned what exactly. I'm sure last time, can I have my slides also?
So you can share your screen.
Okay, fine. All right. So as Shubham has mentioned that, one second. First slide. One second, just come back. One minute, just give me a minute.
Yes, sir. Yes, sir. No hurry, sir.
Introduction. Okay. Can you see my slide there?
We can see it, sir. We can see it.
Okay. So despite of improvement in surgical result, as Shubham mentioned, after esophagectomy, long-term prognosis is still very suboptimal. And however, sometimes lost in enthusiasm over excellent result of cross trial, we are still confused which is the best one. Now, cross is a sole comparison of CTRT followed by versus surgery alone and showing the better result. Rest all trials, as Shubham just mentioned, Neoadjuvant and other trials have yet to. But cross, in my personal opinion, I'll try to put my point, cannot be used to suggest that CTRT is superior over chemotherapy. It cannot be, magic bullet for an entire cancer esophagus that we see in our country. So this is just a point to break, and the youngsters, I'm sure, in the audience would understand that the premise on which, or the investigation which the trial was put on, was on the 6th edition of the cancer esophagus. And now with the 7th edition, is very, very clearly mentioned. It's a different classification, which was not addressed in the cross trial. And I'll explain when the point of that cross trial, which I'm sure Ranil is going to mention, which in my opinion is little and not a good idea to have comprehensive treatment. So you can see here, this is the classification in which the adenocarcinomas are mentioned. And here, both adenocarcinoma and colon cancers, the number of lymph nodes are the staging pattern 1 to 1 and 2 to 3 and something like that. That is where the end stage comes. While in celiac axis and neck nodes were not included. In India, we see majority of patients, and I'll show you some slides here, that the Tata Memorial itself, as well as what we see, is middle third patient, and in Japanese parlance is IM and EA, or rather EI. so that just subcanalian and higher cancers. And they have moderate disease higher up. So that is where the problem arises, that you are treating a subgroup of patient which is lower third, which is there with us, but adenocarcinoma, though increasing, but not as high as the squamous cancer, which forms almost about 80%. So for youngsters, I'm sure they must have known. I can see you the next slide here. The slide is that we see more IM and EI rather than an abdominal esophageal cancer. And in India also, the different treatment modalities exist in different part of India. The most operable patients now either are treated with chemo or chemoradiation therapy, followed by radiation therapy by most of us. And as I said, again, this is TMS data. At least when I got it last, was 80% squamous. Now adenocarcinoma has reached almost 20%. When I joined, it was almost 92 to 8%. But still, the stage 2 and stage 3 still and stage 4 still forms the majority of patients. It's not stage 1 that you see anymore that we in this part. I mean, in my small career, I must have seen just about 15, 20 cases of stage 1 disease, if you talk that. Prashant, it is not going down. Okay. One sec. Next slide. It's not going down. Okay. And everybody will agree that you cannot treat only with radiation therapy or only with chemotherapy. And I'm sure last week, whenever you had last discussion about the surgery aspect, surgery is still a gold standard. And there are 2 papers in this. Of course, when we were, consultant, and Rajan that time was with us, and Badwe did that study of quality of life issues. And that time an outcome had come that surgery still forms the better treatment rather than only chemotherapy or chemoradiation therapy. Of course, probably that time Herskovic trial has not come into and not published that way, that chemotherapy is better when you add with radiation therapy. So, and then again, John Wong's group propagated by a trial that surgery is still a gold standard, and it still exists. So, but my point here to explain to the youngsters, and this is a slide which very often I show, and I'm sure you guys must have seen, that esophagus, is a huge long organ and has got 3 different areas where we need to concentrate. One is, of course, G junction and the lower part of the upper part of the stomach and fundic area. That is, C-word 1, 2, 3. And a different entity is middle third, which is just subcanal and upper middle third area, which is common. And mind well, this is a studies done in Japanese, and this was published by Akiyama, that even if that even if you have lesion down below, you have still almost about 25 to 30% patients who have nodal metastasis. So if you take that cross trial by itself, this philosophy that it is the metastatic disease ignored, we will be definitely not treating majority of patients if you go by this trial. That's my initial assessment here. So you must know the different nodal metastatic area, and you must understand why the Japanese propagate the dissection around the recurrent laryngeal nerve area, which is a very important metastatic site by the nodes. So that's why these 3 fields have been devised. One is on the left. Here is the standard lymphadenectomy, Ivor-Lewis procedure. Here the paratracheal nodes and recurrent laryngeal are not involved, or rather not taken care of. But here, and this is an extended 2-field dissection where you remove the nodes. But what Japanese believe, that the nodes in the neck, in the chest, sometimes are not easy to remove, specifically on the left side. So they try and open the neck. It's not necessary to remove all these other nodes higher up. And I believe that basically the recurrent laryngeal nerve nodes are the greatest bugbear. If you cannot handle them, you have a chance of high recurrences, especially the cases that we get as T2, T3, N plus nodes. I've seen patients with only single node around recurrent laryngeal area, and that forms an N1 disease. So obviously, if you have taken a cross trial, you will not radiate that, and how to tackle that node, obviously is not going to be in the purview of that trial. So what is happening? So let me bring you to few things that I personally do, and I believe that still at the moment we don't radiate too many patients. We do with chemotherapy, and these are two trials that was mentioned earlier by Subham. That Magic trial, initially we used to practice this, and then French trial. Both of them showed that there is a definite benefit of giving them in the surgery alone. But the still survival is just about overall survival is about 23 to 36%, and in other trials it was just about 24 to 38%. But it definitely improved than before. Then came a FLOT, and this FLOT is now a very popular trial, a German trial. It tackles those cases like G junction, as well as a lot of patients higher up, as well as in the stomach. Meanwhile, 80% of these patients were T3, T4 and had all N1s. There was hardly any N0 nodes. So this trial is a docetaxel plus oxaliplatin with leucovorin combination with 5-FU, and you give them 4 cycles before, then operate, and then give subsequent thing. But compared to other common trials as ECF and all, and they showed that there is a definite advantage of giving thing with survival almost reaching up to 40-45% in both the groups. So as you can see here, it comes to almost 50 months and 35 months between the two chemotherapy trials. So NHCT followed by surgery in this fraud group, you can see again there is a huge benefit, almost as good as what cross trial do. So you can't really compare them, but we believe that this is a way to go about. No, it is a very toxic regimen, but our patients are younger, they tolerate it better. Go down. Okay, so in this case, you see, FLOT trial improved the complete resection rate. Now we are talking of a CPR, complete response rate. Mind well, in no trial in most of the other solid tumors, a complete response or a complete PCR is translated into a increased survival. It just definitely improves a little bit, but it has never been proved, and I'm sure in esophagus also it has never been proved. And whatever cross trial say, the survival is still not as much as you would expect in a patient of near 90% or 80% if you have achieved the CPR. So here RGO resection was 85%, and early tumors it became 25% after using a FLOT trial, and 3-year OS survival was almost 57% versus 48% to the other chemotherapy, and you can see a 51 to 35 months survival in the median survival in this group of patients. Now you compare this FLOT to other regimens, barring Cunningham trial or Neo-Cunningham that we are talking about, which has reached almost 5 years, 36%, it is 45%. It is as much as and as good as what cross trial does. So I'll come back to the point why I don't want radiation therapy, and I'll come back when I discuss about cross. No, I don't want to go into details because I'm sure Anil will be discussing about it, and I don't want to spoil his show by bringing all details but I will try and discuss that after he presents that. So mind well, again I'm saying again that if you see here this plot, you can see here it has taken a lot of nodal disease, and nodal disease have done better. Similarly, T3, 4 have done better. Even the other trials have done better. Signet rings have done better. So what I'm trying to bring it, even the elderly persons have done better, which has been excluded in the cross trial. So it is a good trial. Yes, it's a toxic regimen, very difficult, but even tolerated well by elderly persons. Now, in this Neoadjuvant trial, I don't want to go into details. It was an underpowered trial, which Shubham mentioned. But mind well, in this trial also, the response was quite good. And surgical treatment was better because in this arm, 90% of patients had a transthoracic dissection, while Other trials had almost about 40-45% transhiatal dissection, and probably I'll come back to cross. There's the same similar thing. Find out. So here the surgical treatment was as good as the response rate caused by an RT. So you can't ignore that, though it is underpowered. Time, and they were saying there were a lot of complication even in other trials like POET trial, which it was here. There again, there was not much survival benefit, but there were a lot of there were survival benefit of the CTRT, but there were a lot of mortality in this group of patients. While in Neoadjuvant trials, as I said, the 85% CR with 74% completed by the patient, the chemotherapy. And here, Clebro emphasizing increase of non-cancer related death, first and after Neoadjuvant trial, 46% of NRCT patients. So they had a problem. That is why the overall survival dropped in a CTRT arm, and this has to be really considered. So we talk about immediate tolerance, we talk about 1 year survival, but if you have to have a longer survival, you have to consider these points, this thing. And mind well, this part of complications were not notified in the cross result at all. So this has to be also borne in mind that our patients, our Indian patients, have a really not as good as the lung as you will find anywhere in the Western countries. Our pollutions, our pulmonary functions of the patients, our smokers are really not as good as when you do, and especially if you do a good dissection. More the reason if you after radiotherapy, you will have a lot of morbidity in this group of patients. Now in POET trial, majority of patients underwent THE. That was the reason why the surgical results were poor. So my take in this case is, had they done a transthoracic surgery, as there was a randomized trial by Holcher et al. We proved, and now it's decisively proved that en bloc dissection is better than transhiatal. A poor surgery done in this trial cannot be a criteria of selection that surgery CTRT is a better regimen. If you do a good open operation, as mentioned here by Holscher's group, in this group probably also the result would have been better. Now, cross trial, I don't want to go into details, only 2-3 points I just want to mention. Again, this is purely a subcanal disease, even much lower esophageal disease and more patient. Mind well, again, in this group, though there is a good, fantastic survival benefit. There's a good, fantastic benefit between this group of patients, and there is a one sec. Okay, so there is a benefit. So my basic point about cross trial is, first of all, inclusion criteria was as per the 6 AJCCS, and they selected very good risk patient. The length and the breadth was again not given a free hand. While in there is a NSCTRT have 48 months and 24 months, and 5-year overall survival is 33%, with 47 to 33% is a good result. And I'm not saying it's a bad trial, but it's for a very select group of patients who have a lesion lower down in G junction or lower squamous cancer esophagus, which, mind well, a thoracic surgeon like maybe Shubham, or even take Sevita Jivnani or Pramesh or anybody, Dr. Deshpande or me, we clear this very easily, whether a radiation given around that area would help to us get a good circumferential margin. Really not necessary. It's very easy to resect that lower area. The problem arises if the tumor goes up in a higher reaches like subcanal area or aortic arch area, which is not included in this trial. So good trial for lower esophagus and G junction areas. But if you ask me, I have shown the result of plot, they are equally good. If you have to choose CTRT, trial for that. So I will give it neoadjuvant chemotherapy only and not RT. Again, in this case, I'm sure Anil is going to mention is mostly squamous cancers are benefited. Our problem is squamous cancer. Unfortunately, the number of cases of squamous cancers included were very, very low, and they were all early stage cancers. So, and I've seen in Japan, Netherlands myself when I went there, they have proliferative regions. They're hardly crossing the muscularies. So I'm sure you give only radiotherapy, the damn tumor will disappear. So these cases are very selectively cases, and it may be a randomized trial, but because of these, different stages, the selection was definitely biased. So you can't say that they were had all comers or bad risk patients included. And you can see here again in this case also, again stage 0 clinical end stage patients were too many. The patient who had node, relatively not much benefit. Similarly, squamous cancers were benefited, adenocarcinomas were not benefited, and performance status if it is poor, they didn't do well. That is, the results were not as good. And when you compare them with the FLOT, you can see here that, of course, both are adenocarcinomas, both in this, but you can see here the majority of patients in cross trials where you can see here the numbers are less, where these numbers are high here. ECOGs were high compared to that of this thing. So all risk patients were included in FLOT trial, which we believe that if it given, it can take care of all our patients. You can even see N numbers are also higher in this group of patients, and T3 were very, very less here, where it is too many, and T3, T4 were included. So when you compare them finally, you can see here, you can have an HR of 0.77% compared to HR of 0.74 with surgery alone. And margins of free in both the things the same. Consistency was very strong here, it was moderate. They included all poor risk here. And quality of surgery, median number of lymph nodes removed were more than cross trial, because obviously they did not resect the lymph nodes in the upper reaches of the mediastinum. So here I would give more weightage to FLOT for the reasons I mentioned. The pitfalls before Anil takes over, in my opinion, in India, more patients are middle third, so more cervical node metastasis, which is not tackled. Good PS patient included while borderline excluded. Nodal data inadequate as per the 6 AGCS, this thing. N2, N3 nodes were not very many and they were excluded. And radiation-induced fibrosis, which is not very much talked about by anybody who's handling cross trials. There is a definite fibrosis and around dissection area. So it's not easy for our surgeons to do it, because in India, mind well, we are all general surgeons. We are not trained thoracic surgery. So our training process has started now since we have started MCH program. But majority of people who don't have surgical training, this surgery for post-RD patients, if they're delayed, and now they're saying they should operate after 6 weeks or 8 weeks and wait for the longer time, more the reason that it becomes more difficult. And my take is, why add one more local therapy when I can achieve an R0 clearance with surgery? That's it. And I will come back when I have to do that. So overall, 45% of the patient underwent transhiatal, as I said. Extent of lymphadenectomy is suboptimal, very few nodes. Suboptimal situation was taken care by CAT-RT against surgery only group. That's what I believe. And radiation-induced pneumonitis and cardiac toxicity has long-term anesthesia. And last but not least, and I Shubham mentioned this, anastomotic leak rate, 22%. So that mortality and all is not highlighted anywhere. So this is what the crux of the matter is. And these two meta-analyses, as this was shown by Shubham, that joke is hardly any difference. There's no difference between the two groups. And there's another latest meta-analysis, which is here by Dan and Day, and it showed that you can see here the hazard ratio 0.88, FLOT, much better. Similarly, hazard ratio compared to Neos, again, FLOT 0.76, rest all is nothing much. So this shows that there is an advantage of FLOT over cross, considering all the factors that is around. So I would end here, and I would ask maybe the Anil to go ahead and do it. I am not discussing anything more than on the cross trial and other things. Maybe I'll have a chance to put my points after Anil concludes his talk. Thank you very much.
Thank you, sir. Thank you. Thank you. And let me tell you that, statistics are really a funny thing, because what will happen in the next 15 minutes is that Anil will use the same set of studies, because, we go through the
I'm
same
aware
set
of it.
studies.
I'm used to debates like this.
Yes, yes. And
so I kept my weapon still behind me.
we are very sure. We are very sure of your capability, sir, and that is why you were the chosen speaker for this, because you are a very passionate speaker as well as a very experienced surgeon, and I'm sure we give a huge weightage to what you say. But let us hear what.
Yeah, that's why I didn't bring everything point up front. I left it for Anil to come back and show that what he has in store.
Yes. So can you stop sharing your screen? Can you stop sharing your screen so that
yes,
Anil
I will.
Can share?
Okay, stop my screen. Yeah, sure. Okay. Is that
Anil,
okay?
Yes, sir. Thank you. Anil, you can share your screen, and
mute it.
All I can say is best of luck.
Told that he's participated in too many of your meetings, so I'm sure he's very seasoned. He's a seasoned player. I'm looking forward to him. Yeah,
he's a veteran on Cancer Academy, sir.
Oh, that's why. So this is my first test match then. Yes, Anil, please.
Anil, you're not audible, Anil.
To unmute.
Anil, I can't hear you.
Yeah, you have to unmute.
Okay. He's just asking for a minute. I think. Anil, still can't hear you. Still can't hear you. Still can't hear you. Still can't hear you. So, okay, no problem. Take your time. That's not a problem. Okay, no problem. Re-log in, and I will, yes, and I will make you a co-host again. No problem, Anil. We'll wait. Sure. See, sir, this is what you do with seasoned campaigners also. Dr. Sharma, sir.
He will say it is conspiracy. I've done nothing. Sorry.
No. So you have not.
No, I'm looking forward to hearing him. And when youngsters speak, they have better knowledge than me, because I don't get much time to read much. These people are only reading and doing a lot of work, and I'm really proud of all of them.
Now, can you hear me?
Yeah, Anil, we can hear you. Just increase your mic. Just speak up something. I thought I was hearing you.
Very faint voice. Yeah.
Very faint voice.
Can you hear me?
Very faint. Very faint.
Yes, you closer to the mic.
Yes, sir. I'm closer only. I'll start sharing my screen.
Yeah.
His voice is very poor.
थोड़ा सा आवाज अनिल just either check your microphone, उसका sensitivity बढ़ा लो थोड़ा सा. I think that will help.
So good evening, everyone.
Yeah, perfect, Anil. Perfect.
I'll speak louder slightly.
Perfect.
You're not able to hear me. So I would like to thank Dr. Shubham for giving me this opportunity to speak in front of Dr. Sanjay Sharma, who is the most eminent surgeons, oncosurgeons in India. And I would also like to thank him for making me comfortable to speak. So I would, so keeping aside the seniority, I will try to defend my topic, NACT-RT in locally advanced carcinoma of the esophagus. So majority of you must be knowing the NCCN guidelines, the ESMO guidelines. So whatever Dr. Sharma has said, I agree with them, but we have to go by the evidence. So NCCN guidelines do recommend preoperative chemoradiation therapy for the squamous cell carcinoma. And mind you, the NCCN guidelines will not so recommend if they do not have the level 1 evidence to suggest that. So in squamous cell carcinoma, preoperative chemoradiation therapy for non-cervical esophagus. In cervical esophagus, definitely CTRT is the standard of care. And for adenocarcinoma also, in spite of having the flawed regimen, so this is the latest version of the NCCN guideline in 2021, preoperative chemoradiation therapy is the preferred regimen for the adenocarcinoma also. Now, if you are a European or if you follow the European guidelines, the ESMO guidelines also recommend neoadjuvant chemoradiotherapy for the squamous cell carcinoma. In adenocarcinoma, both of the regimen like perioperative chemotherapy or neoadjuvant chemoradiotherapy, both are recommended. But in squamous cell carcinoma, neoadjuvant chemoradiotherapy is also the standard of care. Now, as you all know that there are multiple randomized controlled trials for neoadjuvant chemoradiotherapy in esophagus and gastroesophageal junction, as well as for the chemotherapy also, as Dr. Sharma has already said. And in all that, if you can see on the right-hand side, the 5-year overall survival or 3-year overall survival was better as compared to surgery alone. There is no doubt about that, and there is no debate on that, that you need certain amount of neoadjuvant therapy before surgery. What we are debating right now is whether to give neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy. One of the main highlights in this table is the cross trial, as you can see by the Van Hagen trial. It randomizes 368 patients, and we will discuss that in the future slides. So as already mentioned, the Jokic meta-analysis was published in Lancet Oncology in 2011, so which is an updated meta-analysis by the Jepsky, and it included 24 studies. As you can see, they have also highlighted between the squamous cell carcinoma and the adenocarcinoma. And I should also make it a point that from the 7th edition of the AJCC also clarified that the treatment option or the prognostic significance of squamous cell carcinoma is different from the adenocarcinoma. So the hazard ratio for NACTRT was 0.78 in this particular meta-analysis for NACTRT, and for NACT, the hazard ratio was 0.87. Now coming to the cross trial, it was initiated from 2004 to 2008, and they approximately randomized 370 patients between neoadjuvant chemoradiation therapy versus the surgery alone. As mentioned, both the treatment option or the surgical option, TT or THE, were allowed, so depending upon the thoracic surgeon and the location of the thoracic esophageal disease. And the radiation doses were 41.4 gray in 23 fraction at the rate of 1.8 gray per fraction. If you see the previous table here, all the randomized controlled trial have taken more than 2 gray per fraction, apart from the Taper, Van Hagen, and the Marriott et al., which use 1.8 gray per fraction, which impacts the post-operative complication as well as the toxicity in the definitive chemoradiation therapy also. So, and the chemotherapy regimen was paclitaxel plus carboplatin, and it has been shown in various chemotherapy trials that paclitaxel carboplatin is a well-tolerated regimen and a more safety regimen than the 5-FU cisplatin or the flawed one also, which is a very toxic regimen, as already mentioned. So now coming to the table of the patient and tumor characteristics, 75% of the patients were adenocarcinoma in this particular cross trial, and 25% were squamous cell carcinoma. Majority of the patients were located in the distal third and the esophagogastric junction, as obvious, because these are the mostly adenocarcinoma in the distal third and the esophagogastric junction, and majority were T3, and one disease was present in approximately 2/3 of the patient. Now, what happened to the result? So 95% of the patient completed the neoadjuvant chemoradiation therapy as per the protocol. 94% patient underwent the planned surgery in the NACTRT arm versus 99% in the surgery. However, the resection was not possible in approximately 13% of the patient in the upfront surgery arm as compared to only 4% in the NACTRT arm. R0 resection was better, 92% versus 69% in the surgery alone arm. About the pathological complete response, we know from a lot of prospective and the retrospective study and the subgroup analysis that the pathological complete response is an independent prognostic factor for overall survival. Here, the pathological complete response was 29% for the entire cohort, and for squamous cell carcinoma, it was 50%. That means every other patient of squamous cell carcinoma who received neoadjuvant chemoradiation therapy has got a pathological complete response. As far as the positive lymph nodal status after surgery is concerned, only 31% of the patient had PN plus as compared to 75% in the surgical cohort. Overall survival, as mentioned, the median overall survival was 48.6 months, which matches with the FLOT regimen as already mentioned by Dr. Sharma. However, the squamous cell carcinoma, the overall survival was 81.6 months, which is 4 times the median overall survival from the surgery alone arm. In adenocarcinoma also, the overall survival was better as compared to surgery alone. 5-year overall survival was 47%. Before FLOT trial, no trial in the neoadjuvant chemoradiation therapy as well as the neoadjuvant chemotherapy has shown a 5-year overall survival of 47%. What happens to the post-operative complication? This is a well-conducted randomized controlled trial phase 3. So whatever the bias we are talking about, we should be not be able to, in a phase 3, there is no possibility of a bias or an intentional bias. So pulmonary complication, cardiac complication, chylothorax, the mediastinitis, all were similar in both the group. Anastomotic leakage was 22% as compared to 30% in the surgery alone arm. In hospital mortality, or after 30 days, within 90 days of mortality were also same in both the arms. It's not like that the neoadjuvant chemoradiation therapy has a higher mortality as compared to surgery. Progression-free survival was also better. Squamous cell carcinoma 75 months versus 11 months in only surgical cohort. And do the same with the adenocarcinoma, 30 months versus 17 months. What happened to the patterns of recurrence? When they combine both the CROSS-1 and the CROSS-2 trial, the phase 2 and the phase 3 trial, all the local recurrence, isolated local recurrence, loco-regional recurrence plus distant metastasis as well as distant metastasis were all significantly less in the combined modality arm as compared to the surgery alone arm. As far as the site of recurrence, the anastomotic recurrence, the mediastinal nodal recurrence, the peritoneal carcinomatosis, and the hematogenous recurrence were significantly less in the combined modality arm as compared to surgery alone arm. And as far as the local recurrence, loco-regional recurrence, multivariate analysis, the higher pathological nodal stage, that's N1, the adenocarcinoma histology, and the surgery alone were a significantly poor prognostic factor for loco-regional recurrence. Now, when we talk about the radiation therapy, so because it was a 41.4 gray in 23 fashion and nobody practiced that before the cross trial, the infield recurrences, the marginal recurrences, and the regional outfield recurrences were less than 5% in all that. So the radiation therapy quality assurance was properly handled and properly executed. So there was no marginal or out of field recurrences that we are talking about in the cervical or in the celiac nodal axis. Now, as mentioned, we are the Asian country. Here, the population of the squamous cell carcinoma is 80% as compared to adenocarcinoma of 20%. So whether this result will be applicable to the Indian population, our tumor length is more than 4 centimeter. In TMH also, our median length is approximately 5 to 6 centimeter as compared to 4 centimeter. Our patients are not very good built. So what happens to the squamous cell carcinoma? So there is a Chinese trial which is published as far as the Neoadjuvant trial. It is also called as the Chinese cross. So because it is very similar in design to the cross trial, they also randomized 451 patients and the radiation therapy dose was 40 gray in 20 fraction. The chemotherapy regimen was cisplatin plus vinorelbine and all the standard staging investigation was done. The PET and the radionuclide bone scan were optional. What you can see in this trial particularly is that 82% completed the entire multimodality treatment. The PCR rate for esophagus squamous cell carcinoma is 43%, which is comparable with the cross trial. R0 recession rate was 98.4% as compared to 91.2%. So positive lymph node, the similar. 1/3 only had a positive lymph node after surgery. Perioperative mortality only 2% as compared to the cross trial. So if we are talking about the surgical experience or the surgical details, both of the trials had a post-operative mortality of 2%. One from the Asian trial and the other from the Dutch or the European. Neocritic result. Median overall survival for thoracic esophageal squamous cell carcinoma was 100 months versus only 66 months, which is more than any other trial as far as the surgery alone arm is also concerned for the squamous cell carcinoma. DFS is also 100 months. Here, as you can see, the proximal third was represented in 11% of the patient, the middle third was in 70% of the patient, and only distal third was represented by 20%. So middle third and the proximal third was the predominant location of the disease in this particular phase 3 randomized controlled trial. Now, coming to the post-operative complication, here also in this particular trial also, all the post-operative complication, hemorrhage, the pulmonary infection, pneumothorax, the atelectasis, respiratory failure, empyema, were all similar in both the arms. The only difference is the appearance of the arrhythmia in the chemoradiation therapy arm as compared to surgery alone arm. Here also, the surgical alone arm was a negative prognostic factor for overall survival. Now, coming to the neoadjuvant chemotherapy followed by surgery, as already mentioned by Dr. Sharma, I will not go into the details of that. But however, as you can see here, the MAGIC, the RTOG 8911 alum, and the FFCD and the FLOT, they all have the 5-year overall survival better than the surgery alone arm. So what we are debating here is whether there is any head-to-head comparison between NACT versus NACT-RT. Let's see that. So one of the earlier trials or earliest trial was published by the German group by Stahl et al. In JCO in 2009. Here they have taken locally advanced, the lower esophagus or the cardiac tumor were involved, only the adenocarcinoma. The primary outcome was overall survival. They randomized into NACT followed by surgery. The chemotherapy regimen was the platinum 5-fluorouracil and leucovorin. The trial was closed early due to slow accrual. The primary hypothesis was a 10% improvement from 25% to 35%. In spite of not achieving the planned accrual, the 3-year overall survival was 27% versus 47%, which is approximately 10% more than the planned expected outcome. When you are talking about the pathological complete response rate, here also in adenocarcinoma, the 15% versus 2%, PN0 65% versus 37%, R1 recession rate 4% in the combined modality versus 15%. Median overall survival 21 months in the surgical alone arm in adenocarcinoma versus 31 months. The 5-year overall survival in adenocarcinoma of the lower third is approximately 40% in the POET trial as compared to 25% in the chemotherapy plus surgery arm only. Post-operative mortality was slightly higher, which was not statistically significant, 10% versus 4%. And mind you, the pathological complete response, those patients who achieve pathological complete response, the 5-year overall survival was 90%. No one has shown the 5-year overall survival of 90%. So if you can achieve a pathological complete response, so if the patient is the patient is biologically good responder, they can have a maximum overall survival benefit. Now coming to the Clevebro trial by the NeoRest trial, here the primary endpoint was pathological complete response. Here the primary endpoint was not overall survival. Also, the point to be noted here is that only 74% of the patient completed the 3 cycles of chemotherapy. And as mentioned by the Medical Research Council in the British era, at least 2 cycles or 4 cycles of the neoadjuvant chemotherapy is better as compared to the no chemotherapy. So 80% only received a total dose of 40 gray, which is also lesser as compared to the cross and the Chinese cross also. Now coming to this particular NeoRest trial, the distal and the gastroesophageal junction were higher in percentage. T3 were higher and positive was also in approximately 60% of the patient. Now coming to the result, whatever the primary endpoint had met, it was 9% in the NACT arm versus 28% in the NACT-RT arm. P-value 0.002. Our zero recession in squamous cell carcinoma was 96%. Our zero recession in adenocarcinoma was not different. The positive lymph node, as seen in the earlier trial, was only 35% in the NACT arm as compared to NACT arm, the 65%. And PN0, PN plus will always give you a survival advantage if it has a PN0 status. There was no significant difference between 3-year overall survival in the entire cohort as well as the adenocarcinoma and the squamous cell carcinoma. Here the survival rates are similar. So we cannot say that the neoadjuvant chemotherapy was superior or neoadjuvant chemoradiation therapy was superior. In this, both the arms were having a significant, were having a similar overall survival. Now, as compared to in this particular trial also, if you see the 30-day mortality, 90-day mortality were also similar between the two arms. The surgical complication, here the NCRT is the 38 versus 35%. Non-surgical complication were slightly higher, 31 versus 21%. Anastomotic leakage were also similar in both the arms. Now, coming to the adenocarcinoma, another randomized control trial by the Burmester group, they have included adenocarcinoma, NACT followed by surgery, 2 cycle of 5-FU cisplatin. All the treatment parameters were the same. Here, the radiation therapy dose given was 35 gray in 15 fraction. That means 2.67 gray per fraction. As soon as you increase the dose per fraction, there are chances of late radiation toxicity. Here also the similar finding, pathological complete response was higher, R0 recession was not significantly higher, R1 recession 0%. If you do NACT-RT, R0 recession will be 0 as compared to NACT-RT. Positive lymph node, obviously, only 35 versus 62. Here also, if you see the surgical complication rate were similar, the surgical complication 23 and the 39% in the chemotherapy group. The chest problems were also similar, cardiac problems were also similar, and the anastomotic leak was also similar in this particular phase 2 trial. So this is the summary slide for Burmester, Cleverbro, and Stahl et al., which have shown that the pathological complete response is better in the NACT-RT arm. Now, is there a meta-analysis to say that? Yes, there is a meta-analysis which have compared neoadjuvant chemoradiotherapy or chemotherapy which consisted of the CIS trial. Here, they have concluded that NACT-RT significantly increases the PCR and R0 recession rate. NACT-RT significantly increased the overall survival in squamous cell carcinoma, but not in adenocarcinoma. In adenocarcinoma, the diamond is crossing the unity, so there is no difference between NACT versus NACT-RT. So as we know that there is no head-to-head comparison between NACT versus NACT-RT. So is there any way that we can sort it out? So there are future trials which are going to study the NACT versus NACT-RT specifically in adenocarcinoma, the AGs from the Ireland group, which compared the cross versus magic regimen, the Esophagus, the cross versus flot regimen, the Top Gear Australian trial, the pre-op ECF into 2 cycle versus the magic regimen, and the critic, the Netherlands, the complex trial. So with this, I would like to thank, and I would be happy to take the comment from Dr. Sharma and Dr. Sharma and Dr. Shubham.
Yeah. Thank you, Anil. And I think you started from talking about NACT-RT versus surgery, which has a lot of evidence existing, because most of your presentation walked us through the NACT-RT versus surgery, and at the end you gave us the head-to-head comparison. So I will let actually Dr. Sharma get into the discussion first before I ask a couple of questions. Dr. Sharma sir, the evidence actually presented by Anil, especially the survival data, seems to be really interesting. So I'm sure this is not something which is not there in the public domain, sir. How do you look into that, sir?
Yeah, one sec. Can I have
Anil, stop. Yeah, Anil, stop sharing your screen.
Sure. Just a minute.
Yeah. I'm aware of the trial that he mentioned, though I didn't have the finer nitty-gritties of the Burmester trial, but Burmester trial did show that there is a equal result almost in most of the cases. So I'll just show my screens a few slides, which I say, I'm not saying that there is no role of CTRT. The problem arises here is our patients are a little different. And I'll show you little results of mine. I'm not saying that this is not going to happen. It's probably going to happen because of the newer radiation machine, the techniques of radiation. All these things are going to bring the problems definitely low. But our problem patients are, sticky case, sticky nodes. Surgery becomes very difficult if you add a little bit of radiation therapy. I'm sure now, even Anil and Pramesh and all, you are doing a randomized trial, most CTRT, and probably it will be more interesting for us to understand and know both the trial. And I'm also looking to have a Japanese trial, what you call as 1109, which is going to be, they are doing a 3-field dissection and then radiating this patient as per the cross protocol and giving chemotherapy of both the chemotherapies, be it adenocarcinomas as well as squamous cancer separately. So it will be worthwhile discussing that. So to conclude, my opinions are the neoadjuvant chemotherapy in CA esophagus, in my personal opinion, have come better as if you take use the plot trial, and we have succeeded in this. Adequate surgery and a better surgical skill is required. We need more Shubham Jains and Dr. Jivnani and a lot of people who can really do this surgery without even radiation therapy, and we are doing that in our institution. So I still insist that why give radiation therapy, which is basically more, and that is the same philosophy which Japanese believe, that if they can do a radical dissection with clear margins, RGO resections are high, is like complete pathological response. Why add one more therapy which can add to the morbidity? And so I will wait till I'll wait for the new edges, as well as the what you call as the next trial, which is a Japanese trial of 1109, and they are doing threefold dissection. So I'll just give you a little bit few slides of mine. See, this is the type of dissection we do. See, the trachea is bare, the recurrent laryngeal nerves are bare. Our patient giving radiation therapy with poor lung, I'm telling you, we had lot of problems. We also had some patient in which we gave radiation therapy. The morbidity was very, very high. And if you're getting the result, as I show you, just one sec. Okay, this is the dissection that you can see we dissect, and that's the tissue we remove, the specimen that we remove. We almost remove 80, 90 nodes. Average lymph node removed without any therapy is almost 80, and with some kind of neoadjuvant chemotherapy or chemotherapy, the average lymph nodes are almost about 40, 45. So you can see that this is a data of mine, which is initially published. Now I have done almost 1,000 esophagus. This was published a few years back. I'm trying to work out that. There are 4 periods that I initially was in Tata and then Asian Cancer Institute. We almost 550 odd patients. You see, they are all middle third and this thing cases with 4 periods. Lower thirds and upper third were not very many. At least in this trial, when we do threefold dissection, you can see most of the patients were all T2, T3, even T4. You can see that this much. And mind well, the patient who had upper reaches tumor had almost 60% of paraesophageal recurrent laryngeal nerve involvement. Even in the patient who has subcarinal disease had almost 40%. And mind well, if any surgeon who does lymph node dissection around recurrent laryngeal nerve, I bet they will find it difficult if you give radiation therapy. Yes, if radiation can take care of it without problems, certainly I would be welcoming them, and why struggle and remove the lymph nodes? But probably at the moment, I'm not convinced. And I'll tell you why. I'll just show you. See this. In this, we have done almost 60% of patient preoperative chemotherapy. We have given very few radiation therapy to this group of patients. See the mortality, 1%. Leak rate, 1.6%. All these patients receive chemotherapy. We have average lymph node 40. And I can tell you, my results of 548. See the overall 5 year. In fact, this 90 months follow-up is almost about 50-60%. And if I'm not wrong, Anil would probably know, I have been told that the cases that we did in Tata Memorial before we left, the patients who were 10 year and 15 year in survival were all patients who underwent radical threefold dissection by us. So they are more than 15%, more than 300-400 patients alive. So they have all come after good surgery. So I'm not denying the role of some kind of adjuvant therapy, but I'm little wary of giving radiation therapy to our patients who have subclinical tuberculosis, their lungs are adhesions around, their pulmonary functions are borderline, and they are nutritionally poor. So it is very easy to discuss about the hefty Japanese patients, Chinese patient, German patient, not the same case in India for Indian patients. So I'll be happy to see the Tata Hospital results, which now you guys are doing between 2 field and 3 field, that is one, and the patient between concurrent CT, RT, and CT that you guys are doing. So I'll be very happy to see the result, and I'm I'm telling you, I'll be the first person to start doing that if the results are similar to what we are producing here. Thank you very much.
Thank you, sir. So, Anil, let me put it this way. But by what I make out from Dr. Sharma's talk is that can a good surgery replace radiation? You know, getting more nodes out, getting a better dissection. Can it substitute for radiation? Because believe it or not, radiation does local therapy only. And what Dr. Sharma is showing the results, if you do a good local clearance, you will end up getting the same results, if not better.
So, Shubham, as I understand that, so the thoracic, especially the esophageal surgery, should be done by an experienced thoracic surgeons, okay, and in a high volume center. Could you please tell me how many high volume centers are there in India who can do a very good job with as far as the mediastinal lymph node dissection is concerned? A handful of the thoracic surgeons. You will also agree with me, Dr. Sharma will also agree with me. So when you are talking about a good thoracic mediastinal lymph node dissection, can replace the radiation therapy? I would say no. So probably not, because if you are seeing the result, the data itself is not lying. So because if you see the PN0 rate as compared to PN plus is approximately half as compared to 65% in the neoadjuvant chemotherapy versus the neoadjuvant chemoradiation therapy. We are not discussing about the extent of the lymph node dissection. That means here one can say that the three-field is advantageous, but do we have the evidence to say that in all patients that three-field lymphadenectomy will be better than the two-field lymphadenectomy? That's why the trial is being done in Tata Memorial Hospital, two-field versus three-field lymphadenectomy. When you say the cross trial did not include the cervical or the celiac nodal axis, yes, do agree with that. But the problem is that whenever we say about neoadjuvant chemo radiation therapy for our Indian patient population, the same applies for the neoadjuvant chemotherapy also. The patient population is not going to change for the neoadjuvant chemotherapy. The patient is going to have a weight loss. They are malnourished or cachectic. They are T3, T4, N plus disease. So when we are talking about neoadjuvant chemo radiation therapy, the patient becomes bad. It's not like that. The patient will be the same in the entire Indian population as far as the chemotherapy, if you give, or the neoadjuvant chemo radiation therapy give. So the debate about the Indian population is not so great for the neoadjuvant chemo radiation therapy is wrong. The same population will be receiving the neoadjuvant chemotherapy also. So we have to look as far as the data is concerned. I understand that Dr. Sharma has a good result. So he is not very comfortable, but the data is not suggesting that. The data is not showing an upper hand for the neoadjuvant chemotherapy. They are showing both neoadjuvant chemotherapy versus neoadjuvant chemoradiation therapy are having a similar overall survival rate. How to choose better? That should be our discussion. As mentioned, the patient should not have an TO groove node. As we know that if we irradiate the neck for the TO groove node, there are chances or there are concerns from the thoracic surgeon that they will have the anastomotic leak. So our idea or our motto is to select appropriately the type of patient that can benefit from the neoadjuvant chemoradiation therapy. We know so by the data that neoadjuvant chemoradiation therapy, especially in squamous cell carcinoma, is much better than neoadjuvant chemotherapy followed by surgery also. The debate lies in the adenocarcinoma. So that's why all the future trials are focusing more in the adenocarcinoma. But majority of our patient population is squamous cell carcinoma. So here in our Indian population, squamous cell neoadjuvant chemoradiation therapy is better. Now, if you are talking about the expertise of the thoracic surgeon, you should also talk about the expertise of the radiation oncologist. It's not like that every thoracic surgeon is same. So it's just the same that every center or every radiation oncologist will do the same job. So the Tata Memorial Hospital or Asian Cancer Institute or Max Hospital result can be better as far as the other hospital. I'm not undermining any thoracic surgeon or any radiation oncologist, but it's the experience, it's the high volume center that give you better result if you do in a complex surgery or in a complex treatment. So to say that the patient population is different for Indian population only for neoadjuvant chemoradiation therapy is completely wrong and baseless.
Okay, sir.
One thing I just want to add. I'm not disputing the benefits of chemoradiation therapy. As I said, more and more trials, more and more IMRTs, more and more better stuff. This will definitely improve. But the leak rates of cross trial, this trial, and even if you see, even my colleagues from Japan and from Hong Kong, like Dr. Zhong Wong, Kitagawa, and all, they are scared when the part even the part of the radiation spillage over into the stomach area where we can taking the tubes up or higher area of the esophagus. We are a little concerned about it. We at the moment, as I said, my leak rate is 0%, and we are talking about 90% survival. I have a 93.5% survival in all N0 dissection in my group patients.
So, sir,
survival is the same. Only, as I said, I'm little concerned about the thing that we're doing. I'm for science, and I'll be happy if we are able to think. And I agree with what Anil is saying, that it is high volume centers makes a difference in esophageal surgery overall. Whether you give it CTRT or a chemotherapy, but ultimately the surgery is a very important component, and that needs to be improved. The mortality has to reduce, then only the survival is going to improve. So by means, if you are convinced about that, you'll be better off.
So let me play the devil's advocate here, actually, because when you were talking, you said that radiation increases the level of difficulty for surgery, right? You said there might be more adhesions, there might be difficulty in dissections, whereas the surgical skill that at least the high volume centers would be able to tackle that kind of surgical difficulty if radiation would pose, right? The amount of nodal dissection that you are doing, the lymph node yield that you have, would you really be bothered about the difficulty which radiation poses if radiation were to increase the survival, sir?
See, I'm talking a little bit of the past experiences. I very clearly mentioned with newer modern radiation therapy, these things are reducing considerably. There's no question about it. And I agree with that these modern radiations are much, much better than the side effect that we used to give radiation therapy in earlier cases. So there is no doubt about it. But as I said, once bitten, twice shy, and if your results are good, you don't want to change the scenario too much. And that is one of the reasons why we are in, at least our center, we are not purporting too much. But if given a chance of a lower third squamous cancer, bulky tumor with node, I would definitely do a cross trial or radiate him even up to the upper mediastinum. But I will definitely do the surgery with the same standard of which I do. And I agree with what you are saying, Shubham, that as more and more radiation therapy units are doing good radiation, I don't find it very difficult with my experience and that to do surgery in that. But I'm talking about, as Anil also mentioned, that these surgeries are done at very few centers. So by far and large, if chemotherapy is given and a surgeon who does radiation therapy, probably will be easier for him in a low volume center rather than after radiation therapy. That is the only thing which I'm worried. But I'm not saying that the science has not progressed, and I'm not denying the benefits of giving concurrent CTRT at this stage. Probably in future, if their result in Tata Memorial comes better, I will switch it over.
So I think we have a sort of agreement where Dr. Sanjay Sharma agrees that the radiation techniques are improving and we will be getting better results. And Anil also has a point that this surgical techniques are also improving, and we will be having better surgeons who will be able to manage the post radiation fibrosis better if there are any. I will ask a last question to first Dr. Sanjay Sharma sir and then Dr. Anil, and then actually there are no questions on the chat box to take it, but I think we have achieved what we wanted to achieve by doing this debate, because what we brought out were exactly the two studies which the surgeon and the radiation oncologist showed, and we had similar data shown, but with two different aspects of it, which just shows that it is numbers. You can read it the way you want to read it. So, sir, my last question to you would be that, Anil mentioned about high volume centers for surgery. What do you think would be an optimal number to call it a high volume center for a surgical practice in esophagus, sir?
In other surgeries, it is 20 cases mentioned, but I would say minimum 40 cases are required before you become a good thoracic surgeon for esophageal surgery. That's what my take would be.
No,
My residents do not get more than 5 to 10 cases, but I'm sure when they go out, they will practice. So
in what time frame, sir? In what time frame?
Minimum 2 years they should, and in 1 year you should be minimum 30 to 40 cases. Then you are very high volume center.
So 30
but,
to 40
but,
cases.
but what in our surgical meetings, our all ISO meeting, the consensus among our surgeons in the country is about 20, which I personally believe that in a different circumstances, every patient behave differently. So 20 gives you a good insight. But if you get 10% with chemotherapy and 10 patients with surgery patient, probably the numbers are less.
So what you say is 20 to 30 cases per year, which roughly turns out to be around 2 to 3 cases of esophagus in a month. Okay.
Yes.
Okay. So Anil, let me. I know it's not something which you can divulge further details, but every time we talk of NACT RT versus NACT, we always look to Indian data, and all of us have worked on the NACT RT versus NACT trial at Tata. So what stage it is at? Because when I left, we were at 500 patients something, and that was 5 years back. So I know that the data must be accruing, or so just to ask you, are we anywhere near concluding the study, or when can we expect some answers? Because it's something that I'm sure sir has also worked on too, and I have also contributed. You are constantly contributing, so it's something that we really looking forward to, and I hope like the N0 trial we had for the head and neck, this will be a landmark thing, and it will probably answer the question once and for all, because it will answer all our questions what Sanjay Sharma sir is making about the Indian patient, the type of cancer that we have. You made the point about better radiation techniques, and this is a real world scenario, and we know that the data is pure gold because all of us have contributed to it. So where does it stand actually?
Actually, it stands closely where it was previously. It was very slowly accruing because of the reason that the patient does not want to stay in Bombay because of the logistical issues. And so because of the corona pandemic, we were not able to start any of the patient in the trial. So in the last 1 to 1.5 years, no patient has been accrued. However, given the result of the cross trial and the patient were asking us uh, for the for the for the NACT-RT, so we have actually started doing NACT-RT as a routine practice in Tata Hospital. So the IC will look into that. As far as the accrual is concerned, because it is very slow growing, and due to corona pandemic, no patient has been accrued into the trial for the last 18 months or so. So
Anil, can I suggest one thing? Include 5-7 centers. Tell Pramesh or Savita or George to join us, maybe Shubham's group, maybe Max. In India, we have never been collectively doing things. And we are a fantastic group of people working. So why not? The whole damn thing can be done. Everybody has the same machine. Everybody has the same skills now. Only thing is that large volume centers coming together and do it. I'll be telling you, I'll be the first person to join you.
It's a very good point, sir. Very good point. Because we lack as an Indian is in the multicentricity of the trial.
Correct.
If we start doing the multicentricity trial, every trial will be completed in approximately 3 or 4 years, and we should have the result in 5 years' time.
Can you insist upon Pramesh, and maybe if I meet him, I'll tell him that you should do that. And maybe I'll tell Dr. Deshpande as well as maybe Suraj Pawar and Subramanian Rao down below, or Dr. Murthy, Arvind Krishnamurthy and Delhi group. We can definitely get large numbers. We are operating almost about 150 cases a year, all of us combined, maybe more. I do about 80, 90 cases. I do with my Deshpande together we do about 120 cases in a year. I'm sure if we select also, we will get 50 cases for a trial in every year. You can finish it in next 3 years' time.
Sure, sir.
Yes.
So I think we have reached at least a conclusion that we should wait for the Indian data. But I think sir has also a point that people who are doing good work and can continue to do good work And like what Anil Institute at TMH have done, that they've already adopted NACT RT as probably a standard approach. So both the things are not correct, but both the things are not wrong, but it is up to each one to choose one. But what is important is, I feel that having a tumor board, getting your patient through both the radiation, medical and surgical, and you will be surprised we didn't have a medical oncologist today, and Dr. Sanjay Sharma was batting for the chemotherapy arm for the CA esophagus, which just shows that, you know, we think about each other, and we want the best for the patient, and this is what the aim is. So with that, I would invite Dr. Geeta. Is she around, Dr. Geeta? Oh, just a second. Where's Dr. Geeta? Oh, okay, she is logged out actually.
No mind.
No problem. So with this, I would want to thank Dr. Sanjay Sharma and Dr. Anil Tibdewal for participating in this talk. Sanjay sir, this talk stays recorded on a YouTube channel, and you know, many times we get a lot of requests for a recording of this talk. So people go back, listen to this talk, they go through the evidence which you have presented. So it stays archived, and people have actually written back to us that these talks help them a lot. So
I'm
thank you.
sure I'm in agreement with it. If somebody wants to have it and learn, I'll be very happy.
Thank you, sir. Thank you so much. And with this, we will actually conclude today's topic. It's 9:50, and I'll just put a quick word that next week we are again going on to the concluding part of our esophagus series, that will be talking about the target delineation for CA esophagus, which will be done by Dr. Kanach and Patro from Vizag. And the aim is that we would want to learn more about how to plan the treatment planning for middle third esophagus with vital structures around it. So thank you, Dr. Sharma sir. Thank you,
and
Dr.
thank you very much for inviting me.
Thank you,
very
sir.
much.
Thank you very much.
Thank you. And thanks, Anil. Lovely presentation. Very nice.
Yes.
I'm very impressed.
Thank you very much, sir.
Take care. God bless you guys. Thank you.
Good night. Good night, everybody.
Bye-bye. Good night.
Thank you. Good night.
See you next week. See you next week.